Good morning, everyone. It's Dr. Hall coming at you from the airport. And we're going to talk about Chapter 2, so Evidence-Based Public Health. This whole chapter is organized around the Peri Approach, which is a nice way to kind of think about the different steps in analyzing a public health problem, planning a response, and then evaluating its effectiveness. So the 5 steps are identifying and characterizing the problem, figuring out the etiology, which is the cause of the problem, coming up with some evidence-based recommendations for what might improve or solve the problem, implementing those, and then evaluating them to see if it works. These are the steps within each one of those. We're going to go through those in the course of this lecture. But if this idea sounds kind of familiar to you, you're right. When we talked about the CDC's approach, their definition of the public health approach, you might recall that the first step was assessment, identifying what is going on, what is the problem, and what's causing the problem. Then the next step, and their 3-step approach, was developing policy. What would work to actually improve or solve the problem? And then their final step was assurance. Is it working? So you can see these are just 2 different ways to organize the same process. So it's the same thing, but I kind of like this 5-step kind of way to break it down. So we're going to go through that, and that's what the textbook does. Here we go. Let's start with identifying and characterizing the problem. So in public health, the way we're going to describe a problem is going to be pretty consistent from thing to thing. So what we want to know is, what's the burden of the condition or disease? How much death and disability is it causing? And in epidemiology, which is the study of illnesses in a population, we use 2 different terms. We use mortality, which is to refer to death, and morbidity, which refers to disability. So you'll see morbidity and mortality are often talked about. And then we want to know, what's the course of an illness? How frequently does it arise? How many people in the population have this condition at any one time? And what happens to those people? And we're going to use rates to identify these things. So incidence rate is how many people get diagnosed with a condition over a certain period of time, usually a year. Prevalence is how many people have it at one moment in time. And then the mortality rate is, of all the people who get it, how many actually die from it. So let's go through these one by one. So incidence, what proportion of the population is diagnosed with a condition in a certain period of time? So for example, an incidence question would be, how many people got infected with COVID-19 this past year? And what we're going to do is calculate that as a rate out of all of the total population at risk. And it's super important that we look at rates. Let me give you an example. This is a graph of total confirmed cases cumulatively over time since the pandemic began in different states. And so if you look at this graph, you say, oh my goodness, California, COVID is just out of control in California. Look at that. They have, let's see, more than 5 times as many COVID cases as Wisconsin. What's going on in California? Obviously, they're doing something terribly wrong. Well, actually, if you happen to know that California has a much bigger population than Wisconsin, you'll realize, as does Florida, as does New York, you'll realize we need to control for the population, right? So we need to look at the rate. What percentage or what proportion of people who live in that state ended up getting infected? So when we do that, you can see that it changes dramatically. So now we see that all the states are fairly similar, although California actually has the lowest rate of COVID infection of any of the states here graphed. In the upper left-hand corner, you can see this is per 100,000. So oftentimes in public health, we're talking about things that affect less than 1% of the population in any given year. So instead of using a percentage, because then everything would be 0.1 or 0.02%, we use how many people out of every 100,000 people. So this per 100K, that's usually the units that we use. So, for example, if we wanted to say what was the incidence of chlamydia infection in Dunn County in 2019, that's something that we diagnose pretty frequently at the Student Health Center, we can go to the Wisconsin state data that keeps track of this by county. Our public health agencies do keep track of this. And we'll find out that there were 155 cases of chlamydia in Dunn County in 2019. And at that time, the total population of the county was about 42,700 people. So we'll do our math. We'll say, okay, so 155 out of 42,700 is equivalent to X out of 100,000. And we'll solve for X, right? So you cross multiply, and we will find out that X is 363. So the incidence of chlamydia was 363 per 100,000 in 1 year, which is about 1 in 275 people. Right? Doesn't sound like a ton. We could get a little bit more savvy though, and we could say, well, what's the incidence of chlamydia in young adults in Dunn County in the same year? So there are about 4,000 people who were aged 20 to 24 in Dunn County in 2019, and of those, 66 of them were diagnosed with chlamydia. So again, we'll do our math. 66 out of 4,000 some equals X out of 100,000, and we'll find out that now the incidence rate is 1636, right? So it's about 5 times higher in this group of people. Right? So that's about 1 in 61 young adults. And that can start to give us some clues about a condition if we find it's happening in certain populations or groups more than others. We'll come back to that in the next step. So that's incidence. What about prevalence? So prevalence is at any given moment, say today, what proportion of the population has the condition. So if I were to go around to every person in Dunn County today and test every single person for chlamydia, how many of them, what proportion of them, because it's going to be a rate, are going to actually be positive for chlamydia? And so in order to do this, I need to kind of assess the entire population at one time. So let me show you an example. Cornell University, during the week that ended in December 16th, tested every single one of their students for COVID, whether or not they had symptoms, right? So they went out and did surveillance testing. They tested all of their students within this 1 week period of time. So we'll think of that as one slice in time. These were their results. This is when Omicron arrived at Cornell University. And so it turns out that 1,600 students out of a total of over 28,000 tested positive. So their prevalence rate was 5.6%. Now, sometimes you think, well, 5.6%, that's not a whole lot. But that's about 1 in 18 people. And when you think about how many people are in a typical classroom, then you start to realize, oh, it was everywhere. And so actually, once that happened, Cornell University closed their campus and they went all virtual. So we could also say on any given day how many young people are infected with chlamydia. And so we have national data on this, not Dunn County data, but national data. And it shows us that it depends varying on your age, and it also has changed over time. You can see for ages 20 to 29 on any given day in 2016, which is what this data is from, about 4.2% of people had chlamydia, right? So that's about a 1 in 25 chance that if you have, an encounter with another young person, 1 in 25 chance that they may have chlamydia. Remember, the incidence was only 1 in 61, but the prevalence is about 1 in 25. And so you think, well, gosh, what's going on here? Well, in the case of chlamydia, usually what's going on is that there's a lot of cases that are undiagnosed, right? So you only find them if you go out and test everybody to get prevalence data. So a lot of times people have chlamydia infections for a long time that nobody really knows about unless you specifically test them. Okay, our final rate, so we did incidence and prevalence. Our final rate is mortality rates. So of all the people who get the condition, what proportion, usually expressed as a percentage, will die from it? So I can look at Dunn County COVID data, for example, and find that since the start of the pandemic until December 27th, when I looked it up, there were over 9,000 cases confirmed of COVID-19 and 58 deaths due to COVID. So 58 out of 9361 is 0.006, which is 0.6%. So the mortality rate of COVID-19 in Dunn County is 0.6%, which is quite a lot of people actually. All right. So mortality rates are really interesting for lots of reasons, and we can start to compare them, right? So how does that 0.6% for Dunn County compare to other data, for example? So this is a graph of mortality data from COVID-19 looking at both the United States and the United Kingdom. And we can see a couple of really interesting things on this graph. First of all, we can see that in the winter of 2020 to 2021, really high mortality rates. So, we were up in the 2.5% to 3% mortality rates in both countries. And you can see that that's a little bit higher than it had been, certainly to start in the United Kingdom. And part of what was happening at that time is that hospitals were overwhelmed. And when hospitals are overwhelmed, patients don't get as good care, mortality rates are higher. Then we see this huge drop in mortality rates that occurred at the end of the winter, right? So in February 2021. And that drop happened in both countries. And you say to yourself, well, gosh, what happened? Did we come up with some great new treatment for COVID-19? Actually, no. What happened then was the vaccines rolled out. So when the vaccines rolled out, we saw this massive decrease in mortality rates. And then you see in the United States, it kind of bounced back up and down and up again. And whereas in the United Kingdom, it stayed really nice and low for the most part. And so you might be curious, or you might have already guessed, that one of the big differences there is that in the United States, we have a much lower vaccination rate than they do in the United Kingdom. We especially have a lower vaccination rate for our most vulnerable or our oldest members of our population. So mortality rate can be really interesting. Okay. So in terms of describing the problem, we looked at the burden, the morbidity, and mortality. We used incidence, prevalence, and mortality rates to better understand and start to get some ideas about what's going on. So now we're going to talk about etiology. The etiology is the cause of the condition, the cause of the illness or disease. So one of the ways that we can get clues from a public health standpoint about what's causing a particular disease, so let's assume we don't know the cause, right? With COVID, we now know it, but let's assume we don't know the cause. And I know it's kind of silly, or it's kind of strange to think about, but in the book, you'll see that for the longest time, we didn't know that cigarette smoking caused lung cancer, right? It took us a while to actually figure out what was causing lung cancer. But yeah. So we can look for clues to help us figure it out. So we're going to look at the distribution of the disease. We look at who is getting it, where are they getting it, and when are they getting it. And that can point us to what are called group associations that might indicate risk factors. For example, in the book, they talked about how chimney sweeps were found to have really high rates of testicular cancer, right? So they found that these chimney sweeps were the people who were getting it in the places where they were employed, right? And they were getting it at kind of all different points in their life cycle. And so they said, well, gosh, there must be something about chimney sweeps, that they're exposed to something that increases the risk for testicular cancer, right? And it ended up being the coal dust. Smoking, of course, is another example. So what we saw once rates of smoking in men increased significantly around the time of World War I. About 20 years later, we started to see a significant rise in lung cancer rates in men. Now, women didn't start smoking in any great numbers till a few decades later, and a few decades after that, we saw the lung cancer rates in women start to go up, right? So these group associations can help us deduce what's going on. Another way to think about it is in the more short term. Let's say a whole bunch of students get sick with what we think is food poisoning, right? We're going to say, well, who's getting it? Where were they eating? And when did they eat there, right? So trying to figure out, was it a contaminated food item? And if so, where and what was it? Of course, the epitome of using this approach to kind of identify the cause of the problem was Dr. John Snow's investigation of a cholera outbreak in London in 1854. So his famous ghost map. So he started mapping out who got sick, right? So he was looking at that where, and it allowed him to focus in on that Broad Street pump as a likely source of the contamination as a waterborne source rather than an airborne source. So group associations can give us an idea of what might be the culprit, but we have to be careful, right? They don't always indicate a true risk factor. There can be sometimes what's called confounding variables. For example, you saw earlier that young adults get chlamydia much more often than older adults. But does that mean that young bodies are somehow more vulnerable, or that older people have developed immunity to chlamydia? Actually, no, neither of those things are true. It has to do with how many unprotected sexual partners you're having, right? So there's other variables involved. The book does a really nice example of talking about how in communities where drowning rates are really higher, there are also higher rates of ice cream consumption, right? So does that mean that eating ice cream increases your risk of drowning? Well, no, actually, there's another confounding variable there, which is that in both of those places, it tends to be warmer, right? So people eat more ice cream where the climate is warmer, and where the climate is warmer, people are more likely to go swimming. And the more you go swimming, the more likely you are to potentially drown. So we need to be wary of group associations. They can be a hint or a clue, but they don't always pan out. So when we want to know for sure if something is a true risk factor, we call that establishing contributory cause, right? So once we notice a group association, we know it's a hint, we know it's a clue, but we need to see if it's going to pan out. So we're going to look to see if it satisfies 3 specific requirements. One is, do we see the cause associated with the effect at the individual level? So until now, we've just been looking at the group or population level, right? So for example, when they looked at changes in smoking and lung cancer, initially they just saw these changes at the population level. They didn't go in and say, okay, did more of the people who got cancer, had they been smokers, right? They were just looking at large population effects. So now we want to check at the individual level. We also want to make sure that the cause precedes the effect, right? That it came beforehand. And we want to know if altering the potential cause ends up altering the effect, right? Or the potential disease condition. So these are the 3 questions we're going to seek to answer. And we're going to do that using some research studies. And what's kind of cool is that you don't always need to understand the exact scientific mechanism of how the cause results in the effect in order to identify the cause and often develop some effective interventions. All right, so in order to answer those questions, we are going to use different types of studies. So a case control study is going to help answer that first question, which is the cause associated with the effect at the individual level? And so cases are people who have the condition, controls are people who don't. So we're going to look at people who have the condition or disease, the cases, and compare them to the people without and see what's different between them. And if the cases are more likely to have the potential cause, then that suggests it could be a risk factor. For example, right, let's say students got sick, we think it might be food poisoning. Let's say that there were 10 cases, 10 students got sick, and we're going to compare them with 20 students who didn't and see what's different between those 2 groups, right? So what if 7 out of 10 or 70% of the people who got sick ate at North Point, and only 10% of the controls ate at North Point? Well, that would say to us, okay, this is a potential risk factor we need to look into. Perhaps there was some food poisoning from North Point Dining Hall. Another example, say you go on a vacation with your extended family because there's not a pandemic and there's 15 of you, and 5 of you get sunburned and 10 don't. And of those cases, those people who got sunburned, let's say that 4/5, 80% of them used this new organic sunscreen. And then the people who didn't get sunburned, only 30% used it, right? So that would indicate that perhaps the sunscreen is not as effective. Perhaps this use of this particular type of sunscreen as opposed to a different type is the risk factor here. Now, I want you to notice, right, not everybody who used the organic sunscreen got sunburned, and some of the people who used the other sunscreen still got sunburned, right? So humans are complex, right? There's multiple factors involved. So the presence or absence of a risk factor is never a guarantee one way or another, right? So even if the food poisoning came from North Point, right, some of the people who got sick didn't even eat there. Right? So maybe they got it because their friend brought them something, or they caught it from their friend, right? And some of the people who ate there didn't get sick, right? But that's sometimes you just don't. So we just need to keep in mind that it's not a guarantee one way or the other. What a risk factor does is it increases the likelihood. All right, the second type of study is a cohort study, and that's going to help us answer the question, does the cause precede the effect? So we're going to follow people who do or do not have that potential cause or risk factor over time and see if they develop the disease or condition over time, right? We want to establish that timeline. So, for example, we could follow a whole group of adults, some of whom have high cholesterol levels and some who have normal cholesterol levels, and see over time how many in each group develop heart disease. And so, in fact, that's exactly what they've done with thousands of people over multiple decades in the Framingham Heart Study in New England. So, Framingham, Massachusetts, they've followed all of these folks over time to see which things tend to predict risk for heart disease. And in fact, so here you can see that depending on your total cholesterol level, your risk of developing coronary heart disease, like heart attacks over time, is significantly higher the higher your cholesterol level is. We also see a difference here in your biologic gender, right? So male-bodied people are more likely to develop heart disease than female-bodied people, right? So we can start to identify these risk factors, in this case, for coronary heart disease. So that's a cohort study following people with and without the potential risk factor over time. The third type of study is the creme de la creme of medical research or public health research studies, and that's a randomized controlled study. And what that does is allows you to see if changing the cause ends up changing the effect. And the way you do that is you're going to randomly assign people to either get exposed to the potential cause or risk factor or not, and see if there's a difference in the outcome. Now, this is a little problematic when we're trying to understand risk factors to disease, right? So if I think perhaps that eating Big Macs every day for dinner is going to increase your risk for heart disease, it's not really ethical for me to say, okay, you just got randomly assigned to do this thing that I think might cause health problems for you down the road. Okay, so it's often unethical for public health, for understanding risk factors, to assign people to engage in something that I think is going to put their health at risk, right? Like I'm not going to say, okay, you there, go drink the water from the Broad Street pump and let's see what happens to you, right? So these types of studies are actually not very common when we're trying to determine etiology or risk factors or causes of disease. They are, however, very common when we're looking for potentially effective treatments or interventions. So they are our gold standard to see if a medication, for example, actually works. Okay, so far we have talked about looking at the distribution of disease to identify group associations, right? So we noticed, oh gosh, there's a whole bunch of students who got sick, right? And then we're going to do try to satisfy those requirements to see, does the association hold at the individual level? And we're going to use case control studies, right? Looking at people who got sick versus people who didn't, see if there's a difference in the potential risk factor between those groups. We're also going to do cohort studies to look for the preceding. So wouldn't it be nice to say, okay, I'm going to follow a bunch of people who ate at North Point and a bunch of people who didn't, and then I'm going to follow them over the next 24 to 48 hours and see who gets sick and who didn't. And then number 3 is, does altering the cause alter the effect? Those are those randomized controlled trials. And, I'm not going to randomize people to eat something that I think might be poisonous. So that's usually going to be for treatment or intervention trials. So because we can't always do randomized controlled trials to understand etiology, we're going to look for some additional things to give us more supporting evidence. And there's kind of 4 categories of these. One is we're going to look at the strength of the relationship. Like, how strong does the association appear to be? And the calculation we're going to use for that is something called relative risk. We're also going to look at dose response, right? So for example, if somebody ate the same thing at North Point multiple times, were they more likely to get sick than somebody who only ate it a few times, or did they get sicker? We're going to look for the consistency of the relationship. Do we see this kind of happening again and again in multiple different situations? And biological plausibility. So is it plausible? Does it make sense from a biologic standpoint that this one thing could cause this other, right? Do we have a potential explanation for why that might be the case? So let's take a look at some of those factors with some examples. So let's talk about relative risk, which is how we identify the magnitude of the association or the strength of the relationship. So what we're looking at here is a graph of COVID cases, average daily cases in and its rate, so daily incidence rates of COVID-19, and they've broken it out by people who are vaccinated, fully vaccinated, versus people who are unvaccinated. And the strength of this is that they're looking at, okay, of all the fully vaccinated people, what proportion of fully vaccinated people got COVID? And of unvaccinated people, what proportion of unvaccinated people? Right? So they're looking at the incidence rates within each population, which is the right way to do it. And so what they found is that the daily incidence rate in unvaccinated people was about almost 68, and then the fully vaccinated, it still happens, right? Fully vaccinated people still get COVID, but look, it's much lower. It's 14. So you just divide the 67.8 by 14.2, and you get about 5. So the relative risk of COVID infection for someone who's unvaccinated is about 5 compared to somebody who's fully vaccinated. It's 5 times higher. That's really high. Relative risk, often say for high cholesterol, will be something like 1.3, where you're like 30% more likely to have a heart attack, right? So 5, that's 5 times more likely. That's really high. If we look at deaths too, you'll see we see the same phenomenon. So this case, the strength of the relationship is even higher. So the relative risk in this case, so if we take the incidence in the unvaccinated and divide by the incidence in the fully vaccinated, we get 13. So you're 13 times more likely to die from a COVID infection if you're unvaccinated than if you're fully vaccinated. Let's see if that finding is consistent. So that's looking at national samplings of data. Let's look at New York City's data. And the reason why I picked this data is because the last 2 weeks that are showing us what's happening during New York's Omicron surge. So it starts to give us a little bit of a beginning window into how vaccination performs with Omicron. And so we can see in terms of cases, they're going up citywide by quite a bit. They're going up in both unvaccinated and vaccinated people. But again, look at the difference, right? So in unvaccinated, it looks like we're at gosh, about 800 per 100,000 people. And in the vaccinated, it's maybe 150, right? So the relative risk there, I would take 800 out of 100,000 and divide it by 150 out of 100,000. And I didn't do that in advance, so I don't know, it's maybe 6, right? Well, gosh, that's interesting. That's pretty consistent with what we saw with the national data. So, consistency of effect. This is hospitalization rates. I was particularly interested to see this. We're trying to answer that question, is Omicron more severe than Delta? And how well do vaccines protect against severe illness? And again, we see in vaccinated, unvaccinated folks a much higher incidence of hospitalizations, right, than we see in vaccinated people. So again, the relative risk looks like it's 40 compared to, gosh, less than 10. So you're more than 4 times higher. More than 4 times more likely. Your relative risk is at least 4 for ending up in the hospital if you're unvaccinated. We also have Wisconsin data that looks at this very same thing. And I want to use this slide to point out to you something that's called age adjustment. So you can see here that in this table, and this is data for November of 2021, you can see here the percent of people who had been vaccinated overall in the first column. So that's this column here. And then the rate of cases per fully vaccinated and the rate of cases per not fully vaccinated. Now, what I want to draw your attention to is that overall in Wisconsin, about 56% of the population has been vaccinated. But in the older generation, right, 84% have been vaccinated, right? Now, we also know that older people are at higher risk of severe illness from COVID. So we have to be careful because they're more likely to be vaccinated, but they were at baseline more likely to get severe illness. So of all the people in Wisconsin who are vaccinated, more of them are older. So if we look at the two populations, if we look at the population of vaccinated people and the population of unvaccinated people, the population of vaccinated people is older, like by a lot. Right? And so we have to control for that because otherwise that's going to mess everything up. And we might be seeing that, oh, it looks like the vaccine's not all that effective, but really we're just seeing the fact that there's older age in that group. So that's a long-winded way to kind of point out to you that we do what's called age-adjusted rates. So there's mathematical ways to kind of correct for that and make sure that you're looking at the true impact of vaccination versus not. So let's look at the Wisconsin data and see if it's consistent with the national or the New York City data. So again, this is November data. And so for cases, the incidence rate in fully vaccinated people was 722 for the month. Right? So you're like, oh, that's a lot higher than the daily rates we saw in New York City. Yeah, that's because that's for the month. And in the not fully vaccinated people, we see it was over 3,000, right? So it was quite a lot. Let's look at hospitalizations. Oops, oh yes, there we go. Relative risk is 4.6. So unvaccinated people were 4 times as likely to get COVID. Sorry, my son's plugging in his phone. All right. Now, when it comes to hospitalizations, again, we see this difference. So the incidence per month was 17 for fully vaccinated people and 184. So the relative risk there was 10.8. So unvaccinated people are more than 10 times as likely to end up in the hospital. And then if we look at deaths, we see a very strong relationship again. So the relative risk for death is 12.5. So we're seeing very strong and very consistent relationship between vaccination status and cases, hospitalizations, and deaths from COVID-19. So let's put it all together, right? So group associations give you an idea of what might be going on based on population studies. And then you're going to do some case control studies to see if there's an individual association, cohort studies to look for the timing, randomized controlled trials if you can, but if you can't, right, then you're going to look for this other supporting evidence. So with all the COVID data that I just showed you, we saw consistency, right, from one region and one study to another. We saw strength, right, so really strong impact of vaccination. And of course, there's biologic plausibility. We have a whole scientific understanding of why vaccination would help decrease your likelihood of infection or severe illness. So before we finish talking about etiology, I want to be clear about what contributory cause does and does not imply, right? So a risk factor does not necessarily determine whether or not you're going to get the condition. It just increases the likelihood that you will, right? Not everybody who's unvaccinated gets COVID, and vaccinated people still get COVID, right? It's all about the likelihood. So having a contributory cause increases the chances, right? It's not a guarantee one way or the other. There are other factors at play. Human beings are really complicated, right? Not everybody who smokes gets lung cancer, and not everybody who gets lung cancer was a smoker. Most of them were, but not everybody, right? There are other reasons why diseases happen. Right? Not everybody who has unprotected sex is going to get pregnant or get an STI, right? But those things are more likely to occur in people who have unprotected sex. Makes sense. All right. Once we have an understanding of the problem and the etiology, what's potentially causing it, then we're going to start making some recommendations. So recommendations are, what do we think would work to solve this problem? And we can't just make it up, right? We want to have this be based on evidence, right? Before we're going to implement a policy, we want to have some good reason to think it's going to actually be effective. So we want to have studies on the effectiveness of interventions. And interestingly, studies of the effectiveness of interventions, we have case control studies, we have cohort studies, and we have a lot of randomized controlled trials. So we're going to try to meet all those same requirements. We're also going to look for consistency, strength of relationship, biologic plausibility, dose response. Okay? The difference here is that we want to also consider potential harms or the safety of our intervention. So anytime we're going to do something to somebody, we want to make sure we're not going to accidentally make things worse. And there's a great it's kind of the physician's motto from Hippocrates of the Hippocratic Oath, primum non nocere in Latin, which means first do no harm, right? So whatever you do, please don't make your patient worse. Right, because sometimes the cure is worse than the disease. If you've ever watched somebody go through chemotherapy, for example, sometimes it's really close there. So we want to be sure that the safety of the intervention is also taken into account. So we're going to look at overall benefits versus overall potential harms or risks of any intervention and look at the net benefit, right? Most of our interventions have some risk. We just want to make sure that the benefit significantly outweighs that risk or potential harm. Then we're going to rate our potential interventions based on the size of the net benefit and how good the data is about its effectiveness, right? Because there's different quality of data, right? A randomized controlled trial is much better at telling you if something for sure works than an observational cohort study, for example. So based on how strong the benefit is, right, and how good the evidence is, right, we may give something an A rating. An A rating means we definitely should do it. This is like awesome. This is definitely going to help the vast majority of people. Not that there aren't potentially going to be some harms or some side effects that might happen. Some people might be harmed, but overall the net benefits are going to be substantial, and we have really good data, so we feel really confident about that. Now, if the net benefit is moderate, the data is good, then we'll give it a B. We'll say, yeah, you should do this, right? We're also going to give a B to anything with moderate or substantial benefit that has fair evidence, right? Now, if, however, we're down where there's a small benefit, then we'll say, well, you could consider doing this. That's a C recommendation. Now, sometimes it turns out the net benefit is 0 or negative, meaning people do worse than if we didn't treat them at all. And so those are D recommendations. D stands for don't do it. Okay, so D is don't do it. And then you can see down here, if we just don't know yet, if we just don't have good evidence yet, then we say I for insufficient. I don't know, right? We just don't know if it would be a good idea to do that or not. And so we usually don't. So these are a few screenshots from the NIH, which is the National Institute of Health, which is a research organization in our country, treatment guidelines for COVID-19, for example. And I just want to point out to you, they're telling you the strength of their recommendations, right? So they're saying, oh, this is an A3, so this is an A recommendation. And, oh, I think I'm missing, there we go. And they tell you that the 3 is based on expert opinion, right? So they have some pretty good data and expert opinion, so it's a strong recommendation, right? And so we have all these researchers who look at all of the studies that have been done to see, okay, which are the things that are associated with moderate or significant benefit, net benefit, for which we have good or fair quality evidence. And then we're going to say, okay, we're going to recommend that you do these things. So you might say, well, what about ivermectin, right? And so the status on ivermectin is that there is insufficient evidence. Not that there haven't been studies done, but they haven't been done very well, and the findings are not always consistent. So here I want you to see some studies have showed no benefits or worsening of disease after ivermectin use, right? So that would be a D recommendation if those were the only studies we have. But some other studies showed lower mortality rates. So it's like, we're not seeing consistency of results. And the quality of the data was actually, in most of these cases, especially the studies that showed benefit, was pretty poor. They had really small sample sizes of patients. Patients were also on multiple other potential medications. The researchers knew who was on the ivermectin versus not, so there was potential bias. So there were lots of problems with those studies. So at this point in time, ivermectin is not recommended because we don't have any good evidence that there's clearly a net benefit. And there might be net harm, right? Okay, so once we have an idea of what we think would be helpful, then we need to figure out how we're going to implement it. And this gets pretty tricky. So when we look at how we get it done, the 3 questions we're going to think about are when, who, and how. When we talk about when, we're not talking about today or tomorrow. We're talking about when in the course of the disease or the condition. So when we talk about a primary intervention, that's a preventative thing. So we're going to try to intervene before the disease begins. So an example would be smoking prevention programs, right? Teaching kids to not start smoking, or safer sex education programs and condom distributions in schools, right? So prevent people from having unprotected sex in the first place. Secondary interventions are like, okay, the risk factor has already occurred, or perhaps some early asymptomatic disease has occurred, but we still have an opportunity to intervene. So examples of secondary interventions would be helping people to quit smoking, or in people who are smokers, doing some screening tests to identify lung disease before they become symptomatic, so perhaps we can start treatment earlier. Or in the unsafe sex example, emergency contraception would be a secondary intervention, right? The risk factor has already occurred, but there's something we can do to influence the outcome. Or doing some STI screening tests, right? So, well, you're at risk, let's test you for it. And then tertiary interventions are after symptom onset, the disease has already, or a condition has already manifested, but it's not yet irreversible, right? We can still intervene and do some things to treat it. So treating lung disease from smoking, whether that be COPD, emphysema, or lung cancer, right? Treatments for that. Or if you had a pregnancy as a result of unprotected intercourse, right? You could terminate the pregnancy or choose adoption. Or if you ended up getting chlamydia and having pus dripping out of your private parts, then we could treat you for that infection. So that's what we mean by the when. At what stage in the potential progression of the condition are we intervening? And we have to think about who we're going to target these interventions to. Sometimes we're going to target to everyone. So remember that everyone shift the average approach. Or sometimes we're going to just target those who are the most vulnerable, right? So those kind of higher risk people. So if you think about when vaccines first became available, initially the only people who were able to get them were the vulnerable. So the people at highest risk for severe illness from COVID-19, so the elderly, as well as those most likely to get exposed to COVID-19. So first the healthcare workers and then other frontline workers as well. Or, only those with the greatest net benefit to be gained. For example, we don't screen for colon cancer in people after a certain age, because after a certain age, your life expectancy is pretty low. So the likelihood we're going to be able to improve it significantly is low, right? So them's the facts, right? So we're also going to look at which groups of people are most likely to benefit from our intervention. The stickiest wicket of them all is the how. And we have 3 basic ways that we can implement public health interventions. One is through information and education. So this would be, telling people about these are the things that you can do to reduce the risk of COVID, right? Help stop the spread. These campaigns tend to be what most Americans want public health to do, right? It's just, well, just give me the information and then I'll make decisions about my own life and how I want to do it. The second thing you can do, which is a bit stronger, is give motivation or incentives, right? So for a period of time, you could get $100 in the state of Wisconsin if you got vaccinated. I hope some of you were able to take advantage of that. I know some of you who'd been vaccinated previously were like, oh, that's not fair. I agree, but it's an effective public health intervention. You could also look at the fact that some locations require vaccination as proof, as a requirement for entry, as a motivation, or you might look at that as an obligation or a requirement, right? So we sometimes go to the theater in Minneapolis and vaccination and mask wearing is required in order to attend. So you could say that's a motivation or incentive because I want to be able to go to the theater, right? If I worked at that theater, it might be more an obligation or a requirement. And so that's kind of the most top-heavy method, which is, for example, the executive order currently that businesses with 100 or more employees, their employees either need to be vaccinated or get tested weekly. And most federal workers and contractors must be vaccinated, right? So that's a rule, that's a law, that's an obligation or a requirement. So we have kind of this increasing level of authority, for example, in trying to help affect change in behavior and risk factors. And so personal liberty and autonomy, of course, is going to be the highest with that first one, right? You just give me the information, I make a decision for my own self. And as Americans, we tend to value personal liberty and autonomy very, very highly. We're a pretty individualistic society, actually. We value that really highly. So most of our efforts in terms of COVID-19, especially compared to other countries, have been along the information and education, trying to persuade people rather than force them, so to speak. But the challenge here is that when we look at the effectiveness, the obligations and the requirements are actually a lot more effective at changing behavior. So, for example, with seatbelts, we were seeing tons of people dying in automobile crashes because they weren't wearing seatbelts. So first we passed laws that said cars had to have seatbelts in them, which hadn't always happened previously. And then we went even further and we said, no, you need to wear your seatbelt. It is now a law. So we actually have a long tradition of legally mandating certain things for the public health. But as Americans, we often tend to bristle at that idea, even though that is the most effective way to get change at the population level. And because we tend to bristle at it, right? So there are a lot of legal battles now against the federal mandates because, again, we have to really be careful anytime we are kind of coercing or mandating something that we're balancing those interests of personal liberty against the good of the community. And so it's not just that we want to tell people what to do, right? We're trying to protect the good of the community. And so this quote is often mentioned, so from Oliver Wendell Holmes, right? So talking about that balance between personal liberty and the good of your community. He says, my right to swing my fist ends where your nose begins, right? So what he's saying here is I have the freedom to do whatever I want with my own self, as long as I'm not harming you. Right? And once I'm potentially harming you or another person, that's where things start to shift and change. So for example, if we look at the case of COVID-19, the problem with a lot of COVID-19 infections, a lot of people say, well, I'll take my chances. If I get really sick, I get really sick. The problem that poses at the community level is that it overwhelms our hospital systems, right? So right now in the state of Wisconsin, our hospitals are full. People are waiting in the emergency rooms for hours to days before a hospital bed opens up for them. Sometimes their health condition deteriorates while they are waiting to get the care that they need because everything is just so full and booked that they can't get the care they need when they need it. Not just for COVID-19, but for other things too. Right? So there's all kinds of news stories of people dying of something that they otherwise would not have died from because the hospitals were too full and they couldn't get access to the care that they needed. The other harm that is happening because we're overwhelming our hospital systems is we're harming our hospital workers. So they're not only overwhelmed and working, double shifts and crazy hours that are really stressful and difficult. They're also not able to provide the level of care that they know they should be providing. And so that kind of moral injury is really heartbreaking and difficult for professionals that have really dedicated their lives to doing the best they can for their patients. To be put in a position where they systematically can't do that is really difficult. And so it's estimated that about 1 in 5 healthcare workers have left the profession either through retirement or resignation or what have you since the pandemic started, right? We've had a mass exodus because what we're asking people to do has been exceedingly exorbitant. And so then that further decreases our hospital and healthcare capacity, right? So it makes the problem worse. So it's a big problem. And so we're still wrestling as a country with how we kind of balance personal liberty against the good of the community. Our final step is evaluation, right? Is it working? Is it doing any good? So how is it going? So REACH, is it getting to where it needs to, right? So in our vaccination campaigns, for example, are there areas where people aren't able to access vaccines, and how can we kind of improve that and make it easier for them to get vaccines? Effectiveness, that's huge, right? So is it actually helping and not harming, right? Is it working the way we intended? And if not, why not? Adoption, is it being utilized or used? And if not, why not? Implementation, how do we better get it to that target population, right? So like, mobile vans to go out and give vaccines, for example. And then maintenance, how do we keep this going if it's working, right? So we always want to circle back and see, is our recommendations, our interventions actually being effective? Are they actually accomplishing their goals? And if not, why not? And how can we fix that? So that's why this is a circle, right? So this is everything that we've talked about so far in this lectures, right? So we're going to keep doing this continuous evaluation, continue to go around and reevaluate and see how we're doing, and try to get better and better at helping to promote the health and well-being of our populations, right? So let's quick review. So for problem, we want to know the burden and the course of the disease, the morbidity and mortality. We're going to look at incidence rates, prevalence rates, and mortality rates. In order to decipher the etiology or the cause of disease, first we're going to look at the distribution of disease, the who, where, and when, and look for those group associations to give us clues. And then for establishing contributory cause, right, those 3 requirements and 3 types of studies. So do we see the association at the individual level? Those are going to be those case control studies. Do we see the cause preceding the effect? Those cohort studies where we follow people over time. And does changing the cause change the effect? Those are those randomized controlled trials, or natural experiments sometimes happen. And then further supporting evidence would be the magnitude or the strength of association, a dose response finding, consistency across multiple different studies, and biologic plausibility. Can we explain scientifically why that would be so? And then we always need to be careful. Contributory cause or a risk factor is not a guarantee one way or another, right? That doesn't mean it doesn't have any effect. It has a significant effect often, right? But it's not necessary or sufficient all the time, right? It just increases the likelihood. Then for our recommendations, it's got to be based on evidence, right? We have to have some evidence and studies that show it's likely to work, and we're going to grade them according to the quality of that evidence and the magnitude of the potential net benefit. In terms of implementation, right, we want to also assess the harms versus the benefits. And primary interventions are preventative, secondary are kind of early in the course of the risk factor condition, and tertiary are kind of further down the road once it's developed. Who, which groups? Everyone, high risk, those most likely to benefit, right? And then how, so those 3 strategies of information or education, motivation or incentives, or obligation or requirements, and how do we balance personal liberty with the good of the community. And then evaluation, always, is it working? And if it isn't, why not? And how can we fix it? All right, so that's our evidence-based approach to public health and how we approach a public health problem. I will look forward to seeing you for the next lecture.